My name is Dr. Muhammad Asad Parvez. I'm a consultant oncoplastic breast surgeon at Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore. I welcome you all to our webinar, which is COVID-19 pandemic and breast cancer surgeries. SKM has organized a series of webinars recently during COVID-19 pandemic, and the idea behind these webinars is to impart the knowledge, to share personal experiences with the wider community, and of course continuous medical education. Hence, these webinars are accredited by American Association of CME. Today's webinar is dedicated to breast cancer surgeries during the pandemic. Breast cancer remains, unfortunately, the most killer cancer, especially affecting the women in Pakistan. According to some studies, around 90,000 women, they get affected with breast cancer every year in Pakistan. And unfortunately, about half of them, nearly 40,000 women die of breast cancer every year in Pakistan. With the pandemic, most elective surgeries, they stopped worldwide. However, to avoid cancer-related catastrophes, the cancer surgeries had to resume while the pandemic was still ongoing. And here at SKM, we did the same. Today, we will be talking about the safe processes and the procedures that we adopted at SKM. And we will also share from Aga Khan University as well about their experiences, how they resumed breast cancer surgery during the COVID times. So without any further delay, I would like to introduce our speakers. I personally would be talking and representing Shaukat Khanum Hospital. I would be giving numbers and statistics of breast cancer patients that have been seen and treated and operated here at SKM in the last 3 months during the pandemic. Then we will be requesting Professor Shaista Masood Khan, who is a consultant breast surgeon at Aga Khan University Hospital, Karachi, to give her overview and experience of treating breast cancer patients at Aga Khan University. This would be followed by Dr. Muhammad Zulkarnain Chaudhry presentation, who is a consultant breast surgeon at Shaukat Khanum Hospital. He would describe the experience of seeing patients in the outpatient department and what were the challenges and what were the modifications that were carried out in the outpatient department during the pandemic. And finally, Dr. Amna Iqbal Khan, who is a senior consultant surgical oncologist at Shaukat Khanum Hospital, will give her overview of her personal experience, as well as the challenges that we faced in the operating room in Shaukat Khanum Hospital. Without further delay, I would proceed with my presentation, which is about breast surgery during COVID times at Shaukat Khanum Hospital. I start with this picture from happy times, from the pre-COVID times, when you can see that life was simple and people were smiling, and you could see people smiling right while we were operating. There were no N95s, there were no extra cautions, there were simple linen gowns, there were no, even the anesthetic doctors at the back, they were not even wearing any sort of masks or N95s. And people were standing together. There were quite a lot of people. They all had jobs. And I wonder whether we could ever go back to such happy times while the COVID-19 pandemic is still ongoing. As you all know that COVID-19 started in December 2019 in Wuhan city in China. And it took a couple of months before the first case was identified in Pakistan on 26th of February. And then it took a couple of weeks on 11th of March when the first case was identified in Lahore. When the number of cases increased in Lahore, the Shaukat Khanum Cancer Hospital management took this decision, and all elective surgeries, they were closed, they were stopped on 26th of March. However, the emergency surgeries were still ongoing, but the numbers were very few. The elective cancer surgery was all stopped on 26th of March. This resumed on 13th of April, and initially the surgeries were very few in number, and the patients were chosen. They were only patients who had clinical screening. They were asked few questions, their temperatures, and their history was checked for any contact with COVID patients. And a month later, on 11th of May, all patients undergoing surgery in Shokathanam, they had to undergo COVID testing. And any patient who was tested positive for COVID after that, their surgeries were postponed. And patients who were tested negative, only those patients they had their surgeries. So this bar slide shows number of patients who had breast cancer surgery on weekly basis. The x-axis is the number of weeks, starting from week 1, which was on 13th of April. During the whole week, we only operated on 15 cancer patients. The number doubled next week, and gradually the number slightly increased. Week 7 was the week of Eid, where due to limited number of operating rooms and days available, the number went down. So over last 11 weeks period, we operated 310 breast cancer patients. It was 28 patients every week, which is still lower than our routine, which is around 45 to 50 patients operated for breast cancer every week from before COVID times. However, the trend is upwards, and we are hoping that with the COVID getting under control, the numbers will continue to get better. So this is the weekly beds, number of beds that have been utilized in week 1. The top column, 13th to 17th of April, we were only given 1 bed to admit patients. So we had to offer more day case surgeries. And even in week 2, 3, 4, you can see that there were only 2 or 3 beds available, which means that we could only admit 2 or 3 patients every day for their surgeries. And majority of patients, they had day case surgeries. However, in more recent weeks, we have been getting more beds. So the next, I would be going through some details of the outpatient department and what were the statistics and numbers and what were the changes that were carried out in the OPD during the COVID times. So with the COVID pandemic expanding in Lahore, on 30th of March, all OPDs were closed to the patients. But then 2 weeks later, on 13th of April, telemedicine clinics were started. In telemedicine clinics, patients were physically in their own home or wherever they were. They were not asked to come in hospital, and through video link, either on WhatsApp or through other medias, they were contacted and their history and examination was done. Examination was not carried out. However, a month later, on 6th of May, physical OPDs started where patients were cautiously allowed to enter the hospital and they had their outpatient assessments. The details of the modifications of OPD as well as operating room would be covered later on in today's presentations by the speakers later on. So in teleclinics, again in week 1, we only saw 20 patients. In week 2, only 15 patients, and gradually the number of patients seen every week increased, except for this dip on during the week of Eid. And in physical clinics, in the first 3 weeks, there were no patients who were seen in the physical clinics. From week 4 onwards, the numbers are going upwards. In the last week, week 11, there were 86 patients who were physically seen in the OPDs. So this shows summary of all the patients that have been seen in the OPD, both teleclinic as well as physical clinics. And as you can see that initially, majority of patients, they were seen through the teleclinics, but gradually the shift has changed to the physical clinics, where now teleclinics, the number of teleclinics has although increased, but the physical clinics patients, they have increased further. So overall, in 11 weeks, we have seen 844 patients, out of which majority 445 were seen in the teleclinics. On the other hand, about 400 patients, they were seen in the physical clinics. But we are expecting that in the next coming weeks, the numbers would change and more patients would be actually physically seen. That's where I end my presentation. We'll be taking all the questions later on. And once all the presentations have finished, then we will be taking all the live questions. Thank you very much for your attention. Our next speaker is Professor Shaista Masood Khan, who is a professor of surgery and consultant breast surgeon at Aga Khan University Hospital, Karachi. She has been awarded Sitara Imtiaz as well, and she will be sharing with us her experience of treating COVID patients in Aga Khan University. Over to you, Professor. Thank you.
Assalamu alaikum, everyone. Thank you very much for giving me this opportunity to be able to participate in this very important and crucial event that historically will go down into centuries. We all know about the pandemic and the effect or the impact of it on the surgical practices. For breast in particular, there have been some recommendations that have come through in terms of from the American Society of Breast Surgeons, just to name a few, and from the Society of Surgical Oncology. There have also been recommendations that have come through from Europe, but most of them are covering or approaching it with the same context. As far as breast is concerned, the patients have been prioritized into 3 groups. The recommendations that have come through was derived after experts in the multidisciplinary management of breast from multiple representatives of cancer care organizations were invited. The idea was that the recommendation should be primarily preliminary to decide for the triage and identify the treatment of patients with breast disease, not necessarily exclusively breast cancer, during the COVID-19 pandemic. These have been identified as recommendations. They are not rules, they are not strict guidelines, and they are not to supersede individual physician judgment, nor institutional policies or guidelines. In particular, it should be taken in the context of each institution's, I would say, geographical location, the resources, the prevalence of COVID-19 in their own region. And as we have seen, and you will see that in the last few months, as we get to know more about this disease and disorder, the recommendations were identified to be subject to changes with changing COVID-19 pandemic, and we have also brought about changes in our own recommendations and practices. So based on the multiple groups that came together, the patients are to be categorized into 3 groups. We can say category A or priority A, priority B, and priority C. Priority A is considered to be urgent, where the patient's condition is immediately life-threatening and clinically stable. Now, this prioritization, if we were to look at it broadly, will not be confined only to breast cancer. It is applicable to all surgical patients. And therefore, in general surgery, for instance, you will find more and more patients who will belong to priority A. As far as breast is concerned, you will see that there are very few patients who would fall into this category. Priority B is a patient situation is not critical, but delay beyond 6 to 8 weeks, and one can even take this up to 12 weeks, could potentially impact overall outcome. So in this group, the target would be that intervention, surgical intervention, if possible and if required, should be done within 12 weeks. Priority C is patient's condition is stable enough that services can be delayed for the duration of the COVID, i.e. you can defer it till after the pandemic is over. So in priority A, what do we see? The ones that will be considered as urgent. And again, when we come to our algorithm in determining the status, corona status with the testing, If the patient requires it, and even though the patient may be positive for COVID, we may have to go in and operate. Top of the list, again, as I said, is not breast cancer, but breast abscess. One could consider aspiration, but one can also consider incision and drainage. Post-operative hematoma that warrants evacuation will come under this category. A mastectomy flap that has undergone ischemic loss and warrants revision should be undertaken as priority A. Following autologous reconstruction, if there is a need for revascularization or revision, only already reconstructed breast where there is ischemic changes, that they could be considered as urgent, but no reconstructions are to be performed during the pandemic. A patient who is on systemic therapy but presents with progression of the disease locally, she would qualify for immediate or urgent intervention. Malignant phyllodes tumor should be considered for urgent. And then this last group is an interesting group where we encounter triple negative tumors. Now we know that triple negative tumors, if they are of substantial size, anything more than T2, whether it's N0 or N1, should be subjected to neoadjuvant chemotherapy. In T1 lesions, we don't expect much response, and there isn't really a strong indication for neoadjuvant chemotherapy, that they would fall into this group and would qualify for surgical intervention. However, if this is T1C lesion, we may consider neoadjuvant chemotherapy. Coming to the second group, which is priority B, and most of our patients would really fall into this group, which are the ones that would require intervention, as I said, up to about 12 weeks. And amongst this are those patients who have already received neoadjuvant therapy, be it neoadjuvant chemotherapy or neoadjuvant hormonal therapy. So triple negative invasive tumors, post neoadjuvant therapy, now they have completed the neoadjuvant chemotherapy, and therefore they should be subjected to definitive surgery, as I said, within or up to 12 weeks. ER negative, which is ER negative and HER2 positive invasive tumors who have received neoadjuvant therapy. So besides triple negative, the ones who are HER2 positive, they would also qualify for surgery within about 12 weeks. In terms of diagnostics, if there is discordant biopsies which could be malignant on excision, such patients would be allowed or would be permitted to have a diagnostic interventional surgical procedure to come to a conclusive diagnosis. Priority C, where the patient's condition is stable and the services can be delayed for a duration till after the COVID pandemic is over. This is a fairly exhaustive list. So we say you have estrogen receptor or hormone receptor positive tumors on the left, and also hormone receptor negative and hormone receptor positive on core biopsy. They should essentially be started on neoadjuvant therapy if they are ER negative, and they should be responsive. If they are showing response, they could be deferred till after the pandemic is over. In ER positive tumors, of course, we are in a better situation, and we can start them on hormonal therapy for as long as even 6 months or longer. Diagnostic biopsies yielding high-risk lesions, atypia or papillomas, or borderline fibroepithelial lesions, fibroadenomas or phyllodes, both of these could be deferred till after the pandemic is over. The same is applicable for sentinel node that was identified to be positive and requires a repeat sentinel node, could be deferred till after the pandemic is over. DCIS, whether they are estrogen receptor positive or negative, and they are non-progressive, that their surgical intervention could be deferred. Others would be prophylactic surgery, reconstruction, and duct excision for nipple discharge. These are certainly not at all considered to be urgent enough to warrant intervention. This is an algorithm that we have derived at Al Khan University And this is applicable to all patients who are to be undergoing surgery, whether it's general surgery, neurosurgery, or orthopedics. So at the time of presentation, be it as an acute emergency in ER when they present, and we go in and do a pre-op COVID test and it turns out to be positive. We have a centralized arrangement where it is informed. If it's an emergency, which means it's either a red emergency, an orange emergency, if the patient is COVID positive, we would take the patient into a dedicated COVID theater and no further, sort of questions would be asked. If it is not an orange or a red emergency and it can be delayed, then we categorize it into 3 groups. A surgery that can be delayed for up to 14 days, and here we are looking at impending hydrocephalus, herniation due to brain tumor, and again, as we said in the first group that we had identified breast cancer patients, then we would proceed with surgery. If they are still positive, then if either they go into the dedicated operating room or they could come to the regular operating room. However, if we can delay the surgery from 14 days to up to 3 months, and here most of our patients will come in, then we would repeat the COVID test after 14 days. If the test turns out to be negative and the patient is asymptomatic, then we would proceed with surgery. If the test is positive, we would wait for another 14 days and then repeat the test. We would also, however, if the test is negative but the patient is symptomatic, we would consider this to be as suspicious and wait for 14 days. After 14 days, we would repeat the test and then see where the patient falls. However, if there are more than sort of 2 months have passed since the first test that has been repeated, we can proceed with surgery belonging to now the 3rd group, which is whether you can do it now or you can do it later. What we have done is we have brought about a minor change in this area. So instead for waiting for 14 days, if the test turns out to be positive, we are now repeating the test after 7 days. And again, if the test is positive, we wait for 7 days and then go back and repeat the test. What has our experience been in terms of the operating room? Now, these slides have been provided to me by Dr. Asad Latif, Chair of Department of Anesthesia. This has been our experience. The different phases that have been referred to is the number of theaters that have been available. So in phase 1, we had less than 6 theaters available. In phase 2, we progressively increased, and you can see that there were substantial number of members from theater that were quarantined. The blue shade tells us the number of individuals that were quarantined. How many of them returned from quarantine? How many were positive? And how many came back after being positive, they came back to work? That's the yellow line. The remaining total exposure versus the current quarantine, obviously there has been some stabilization in those figures. As far as the anesthesia is concerned, this is a representation of the entire staff, from consultant to resident to nurses, technicians, anesthesia technicians, OR technicians, administration, and healthcare providers. And we can see that the highest number where they turned out to be positive was essentially our support staff, not the consultant and not the residents. When we look at elective surgeries, and that takes care of all surgeries, not exclusively breast only, there has been a gradual and a progressive increase in the number of COVID rates from May coming down to June, where we are saying 16% of them, of the total elective planned cases. So in between 11 and 15, we had 99 cases, of which 6% were positive. And we can come down and see that this has been in June, it has gone up to as much as 16%. When we break it down, the biggest number that where we had to do cancellations because of COVID positivity was general surgery. I think that's about all that I need to share. Thank you. I'll be happy to take any. Do we take questions now or later? Hello?
Yeah, I think we're going to plan questions at the end of the session, Dr. Shasta. Thank you so much for your wonderful presentation.
Okay, thank you.
Thank you, Professor Shasta. That was very informative. We will take the question answers at the end of today's sessions. Next, I'm going to request Dr. Mohammad Zulkarnain Chaudhry, who is a consultant breast surgeon at Shaukat Hanum Hospital. He is going to tell us briefly the experience of outpatient department and what modifications have been done in the outpatient. Thank you, Dr. Zulkarnain.
कागज तो नीचे लग रहे हैं Assalamualaikum. I am Dr. Mohammad Zulkarnain Chaudhry, and I am one of the breast surgeons at Shaukat Hanum Memorial Hospital. I think we are a little bit short of time now, but anyhow, I'll be very, very brief, and my presentation is also very brief because there is not much for me to say about what changes we have done to our patients coming up into our outpatients department. But today I'm just going to highlight very briefly the changes in the outpatients department services which are affected by the COVID pandemic, and I'll give you a brief description about the changes occurring in the outpatients department. As per hospital policy, it's a consultant run service, so every patient is seen physically by us, by the consultants. So new patients are seen in one-stop breast clinic, and returns and follow-ups are seen in the outpatients department's clinic. And before the COVID pandemic, each consultant would see about 48 patients, new patients in one-stop breast clinic per month, and about 200 return patients in the outpatient clinics per month. So among all of us, like all of our 3 consultants, we would see about 150 new patients in one-stop breast clinic, and about 600 to 650 return patients in the outpatients department. So I just want you to keep this in your mind that we used to see about 150 to around 160 new patients in one-stop breast clinic among all 3 of us, like myself, Dr. Amma, and Dr. Hassan, while we would be seeing about 600 to 650 return patients in our follow-up clinics in the outpatients department before the COVID pandemic started. As you know, that one-stop breast clinics are fast-track clinics where patients are seen, investigated, discussed in multidisciplinary team meetings, and the treatments are then started within 3 weeks' time. And only new patients are seen in one-stop breast clinic, while follow-ups are seen in outpatients clinics or outpatient clinical departments. So when we had our COVID pandemic, all the hospital activity was suspended and because of COVID-19 pandemic in March 2020. And you could see that the OPD closed due to lockdown on the 25th of March till the 14th of April 2020. That was to say about 20 days that all the activity, clinical activity, was suspended in the hospital. And then it reopened somewhere in the middle of April on the 15th of 4th, 2020. And at that time, we started with teleclinics. Basically, in the teleclinics, patients were booked and they were informed at least 1 or 2 days before they were being seen, they were being contacted in the outpatients department, and where they were contacted either on the telephone or they were contacted either on the WhatsApp, and they were asked about their clinical problems. History was taken, and just basing on the history, so patients were booked for their investigations in the radiology department for the next 1 or 2 weeks, where they would come to the outpatient to the radiology department for their mammogram, ultrasound, and their biopsies. Once they were all done, we generally they were done within the next 2 to 3 weeks time, and then they are discussed in our multidisciplinary meetings, and then the decisions are taken for their treatment. So these teleclinics are still going on. Along with these teleclinics, physical patient clinics were also started from the 6th of May 2020. And in the physical clinics, still the number of patients is quite low. So we are it's a consultant-wise clinical breakup. We are 3 consultants working in breast clinic, in the breast department. Dr. Asad, myself, and Dr. Amna. So from the 15th of 4th, 2020 till the 5th of the 6th, 2020, Dr. Asad had seen about 132 patients in his clinics. You can well imagine that is a period of about 1.5 months where a single consultant has seen about 132 patients, while before the COVID period, consultants were seeing about 200 to 250 patients per month. So this is for, say, about Dr. Asad might have seen about 100 patients, which is nearly half of the number which was being seen in pre-COVID time. And patients seen by Dr. Amma were nearly the same. I was not around at that time, so I had only seen a few patients because I myself was ill during that period. So as I told you that the physical clinics started somewhere in the early May. So up till now, till the early June, Dr. Asad and Dr. Amma have seen, say, about nearly 100 patients each, which is still the number is still nearly half of what they had already been seeing in the pre-COVID time. So, so what are the differences from the routine OPD clinics which we used to have after the Corona time? There are a few things which have been made compulsory for the medical staff as well as for the patients. Everybody is asked to use masks, and masks are made compulsory for the patients and also for the paramedical and staff and the medical staff. Social distancing is being observed. Everybody is asked to keep a distance of at least about 2 meters between each other, and there's a lot of emphasis being paid on hygiene, hand hygiene, where the sanitizers are available in the outpatient for the patients as well as for the doctors. as I've already told you that the number of the patients is nearly half, rather it's about less than half of what we have been seeing in the past in the pre-COVID time. Attendants are not allowed to come into the outpatients departments. It's only the patients which are allowed unless and until the patients are of such a condition that they have to be attended by an attendant, then the attendants are allowed to come into the outpatients department. Specifically, what happens is that the patients, once they come into to the hospital for their appointments, they've been checked and they've been screened outside the hospital, and they are asked to wait at least about 20 minutes before their appointments, and so that there is not a lot of crowding occurring up in the hospital outpatients department. As I told you, that screening is done on the entrance of the hospital. Suspected cases are then sent to the COVID camp, where they are screened for their infections. Yes, obviously the risk of exposure is increased for the patients, paramedical and medical staff, and patient satisfaction, as you know that patients are being seen on the teleclinics, not on the physical clinics as much as they used to be in the past, so it is definitely compromised. So there is not much for me to talk about as there are very few changes rather regarding the patients in the outpatients department, but the number of patients has specifically reduced to nearly less than half of what we had been seeing in the pre-COVID time. Thank you very much.
Thank you very much, Dr. Zulkarnain, for giving a brief overview of what changes were done in the outpatient department to carry on safe practices of surgery and seeing patients of breast cancer in the hospital. Next, I am going to request Dr. Amna Iqbal Khan, who is another consultant surgical oncologist and breast surgeon in Shaukat Khanum Hospital, to please share with us the experiences that we had in the operating room, the difficulties and the challenges that we faced, and how did we overcome them in the operating room. Over to you, Dr. Amna. Thank you.
Can everybody hear me now?
Yes, we can.
Okay, great. So thank you so much, Asad and the rest of the team, for giving me an opportunity just to go over how we managed the operating rooms during these very challenging days. As a surgeon, I'm sure we all know that the operating room is our special home. It's our little sanctuary. And for me personally, it was really, really disturbing to see all the turmoil that was happening in my little safe zone. But thankfully, we're over most of the difficult part. I'm hoping, fingers crossed, and hopefully we'll be moving towards some sort of normalcy, inshallah, in the weeks and months to come. So I'm going to just concentrate on what we did in the operating room with a little bit of an overview. This is kind of a revision of what briefly was mentioned to you guys initially. Also, we were doing anywheres close to about 45 to 50 cases a week on the service before COVID times. Middle of March, we started realizing on a national level that this disease was going to become significant. And on the 23rd of March, lockdown was introduced in the city of Lahore. It was interesting that the first floor that was given up, inpatient beds that were dedicated for COVID patients, was the surgical floor. So as soon as that happened, we basically lost all of our inpatient beds in our dedicated floor. We were given some alternate beds on different floors, but that was the first thing that came and hit us as a service. Surgical lists were discontinued, OPDs was discontinued. Once we had an idea of what the number of patients was going to be like, we decided to open up the surgical services slowly for Shaukat Khanum and expand from the emergency surgeries that had been happening during this time to include some of the elective cases. Dr. Shaista gave an excellent overview of what these, what the prioritization of these surgeries should have been, and that is pretty much what we were following over here also. It's interesting that breast surgery was the first elective surgery that was resumed in the Department of Surgical Oncology here at Shaukat Khanum, and our OR lists started from the 13th of April. We had a very, very slow and very cautious start, starting with 2 to 3 cases a day, and majority of them were planned and managed as day cases. We picked up the patients who were clear day cases and then slowly went up to those patients who could be potentially operated on and safely discharged on the same day as the operation. The aim and objective of doing these day cases first, or doing cases which required minimum inpatient stay, was that God forbid if we needed to dedicate more beds in the inpatient unit for our COVID patients, then it would be easy to manage to do so. So we started with at least 2/3 of our cases as day cases, and slowly 1 and then 2 inpatient beds were given to us, and we started admitting patients and doing some of the bigger surgeries, including the mastectomies and the axillary lymph node dissections on our surgical list. 2 weeks into our elective surgeries, we started doing pre-op COVID testing, and the numbers have been creeping up, and now we are almost back about 80% in terms of volume to where we were compared to the pre-COVID times. The COVID testing policy is also interesting. We initially were taking patients without any COVID testing, which happened in the first 2 weeks, and all precautions obviously were adhered to as much as possible. Subsequently, we decided to do COVID testing in all of our elective operations, and this was done 72 hours prior to the date of surgery. The test is generally reported within 24 to 48 hours, so we knew that if the patient was to go for surgery, we would know the status of that patient at least 24 hours in advance. If the patient tested negative for COVID, we proceeded with the surgery. If the patient tested positive for COVID, and I'm going to remind everybody here that these are elective cases that we're talking about, these patients were then postponed for a duration of 2 weeks. And if the patient was stable and asymptomatic, we did not go for repeat testing in these patients. This was all in consultation with the infectious disease department and the protocols that were laid down by the institution. So I think this is just a snapshot of our holding area. Pre-operatively, patients come and wait, and we instituted social distancing. We instituted face masks in all patients and tried to adhere to the guidelines as much as possible. I myself personally felt that it was very, very disconcerting to actually book these patients for surgery without a recent clinical examination. Teleclinics were happening. We were booking patients through teleclinics, but unfortunately, I felt that they were very unreliable to really find out what the clinical status of the patient was, especially in our post-chemotherapy patient, where we rely a lot on what our physical examination tells us and what we feel with our hands about what the status of the breast mass and the lymph nodes is when we're prior to planning surgery for these patients. So the best possible option for us, since the OPD was closed, was to examine these patients in the pre-op holding bay, and markings were done at that time. We did have to change the plan of surgery in some of these patients, as was expected, but I'm glad that there was no major shifts that happened, and none of our patients who were planned for breast conserving surgeries post chemotherapy ended up having a mastectomy, which I feel was really good. Patients' arrivals were staggered. We were doing these as day cases. Most of them did not get pre-op admissions, and we would stagger the arrival, kind of anticipating how long each case would take to minimize the time that the patient would spend in the hospital, especially in the pre-op holding bay, just waiting for their turn to come in the OR. The other thing that we did was to minimize the number of people in the operating room. Attendants were not allowed for all stable patients. So most of these women who came for surgery for breast cancer came by themselves and were not allowed an attendant inside the OR premises. Certain changes were made by the anesthesia team at the time of induction. We minimized the number of people in the operating room. There was one anesthesia consultant, one resident, and one technician present in the operating room, along with the scrub staff. Full PPEs were made mandatory, including an N95 mask covered with a second tri-layer mask, plastic shields or goggles for the eyes, and then covers were also provided to cover the patient during the aerosol generating intubation procedure. So the patients were covered and the physicians were covered also at the time of induction. The number of air exchanges in the operating rooms were optimized, and it was calculated the entry of surgeons and other staff that were not needed at the time of induction would be delayed by 15 minutes to ensure their protection. And that was another change that was instituted in the operating room. For a surgeon, the things that we changed when we started operating on these patients were donning of full PPEs, which included either goggles or face shield, N95 mask covered by a tri-layer mask, and then the gowns and double gloving. It's interesting because the initial face shields that we had limited visibility, and it was a little bit of a struggle to actually try and reach some sort of a compromise with management to improve the quality of the face shields or provide goggles that were really good in terms of ensuring visibility. These changes were, the management was happy to help us to institute these changes, but in the beginning, I do remember a little bit of a juggle act that we had to do, trying to make sure that with all of these extra things that we had, that we could continue in a safe way with the surgeries. I think getting used to the N95 was a little something that took me some time also, because they are really, really tight-fitting masks. And in terms of not just breathing, but communication with the scrub nurses and what other people in the operating room was also a little bit testing in the beginning. I think now we've all gotten used to it, and we've kind of reached a new equilibrium in this COVID era, so it's not as cumbersome anymore. This is just a snapshot of what the operating room looks like now. You can see the double masking and the shields and the double gowns that we had, and minimum people in the operating room. Most of the cases we did with a surgeon and one assistant. In some tedious cases, we had the second assistant come in, but we tried to keep that to a minimum also. Another big thing was transition between cases and the lag time. In our pre-COVID times, the transition was actually very smooth and efficient, and we were able to kind of whisk patient out and the other one in about a duration of 15 minutes. Once COVID time started, and after this pandemic, we had to take care of a lot of things in terms of cleaning of the operating room and being careful in terms of not just intubations and extubations, but also the general environment of the room. And as was expected, we almost increased our time between cases fourfold. So our average time between the 2 consecutive surgeries now was about 50 minutes, which is the time between sign out of the patient exiting the OR and the next sign-in of the patient starting the next surgery. It did decrease the number of cases that we were doing, or maybe our efficiency of doing cases, but it was the safest option that we could practice. And we're hoping that this time will be decreased as we get more and more used to these new protocols. This is a snapshot of our post-anesthesia care unit. As most of our patients were day cases, they did spend some extra time in the PACU. The beds were distanced a little bit more than they were in March and before. Patients were given masks and they wore them at all times. The attending technicians and the attending nurses in the PACU were all wearing their protective equipment, and patients were stabilized, made pain-free, ensured that they were tolerating by mouth, and discharged from the PACU. As far as the operating room is concerned, I think that's pretty much everything that we did in a nutshell. And with that, I am just going to conclude what I wanted to share with all of you. Back to you, Asad.
Thank you, Dr. Amna, for giving a comprehensive overview of the operating room, especially the pictorial review of the COVID times. And now we'll be taking the question and answers. So we'll see if we have received any online questions. I would like to start with a question myself from Professor Shaista Khan from Karachi. So, Madam, thank you for giving a very good presentation and detailed overview of breast surgery in Aga Khan University. I understand from your presentation that you were postponing the patients who were tested positive for COVID, the cancer patients, but then you were repeating their tests a week later or 2 weeks later, and you were only offering surgeries to them who were tested negative on a repeat test. Here at SKM, our practice has been different, as Dr. Amna has just described, that we were waiting for 2 weeks. For those who were tested positive, we would wait for 2 weeks. And if they remain asymptomatic and they don't develop any symptoms, we would not repeat their test and just go ahead with the surgeries. So please share your experience that if you were testing them, how many were still positive and whether there was any disease progression while waiting. Thank you.
Thank you very much. I think that's a very valid question. As a matter of fact, we were taken by surprise for other specialities where the patients were taken as elective and were on clinical screening were asymptomatic. But when they were tested after the surgery, because certain features developed, they turned out to be positive. So we were very, very cautioned after that because significant number of our theatre staff had to be quarantined. So at 14 days, we would repeat the test. And then if they were positive, and I would say about 1/3 of those that were positive would still remain positive after 14 days. And these are, I'm referring to breast cases. Now we have changed the practices slightly, and instead of repeating at 14 days, we are repeating at 7 days. But we also take this into consideration that if they are symptomatic, and even if the test is negative, we will consider them as positive. So without repeating the test, our protocol is very strict. And anesthesia would not allow any patient who is to have a GA to come back in without a repeat COVID testing. And that also, if the surgery cannot be postponed, then of course we will take them to the COVID dedicated theater. So it's not that we would deny them surgery, but then we would accommodate them into the dedicated theater.
Sure, thank you. Have you noticed any disease progression during these difficult times, that because patients had difficulty accessing the healthcare and being positive in certain patients, whether they were denied treatment and they progressed to further stages?
Well, no, not really. I think more so in terms of local progression, perhaps. But obviously, we have not repeated the systemic disease progression by repeating any advanced imaging. But locally, there have been, I would say, about 10% of patients that have shown some progression, but not that they were rendered inoperable, no. So for conserved breast, yes, the lesion got a bit bigger. In axillary clearance that we were waiting, the nodes got a bit bigger, but not otherwise in terms of systemic spread.
Sure, thank you. Next, I would like to ask a question from Dr. Zulkarnain Chaudhary. That within the OPDs, my personal experience is that the physical patient assessment is much different to a telemedicine clinic. Having an assessment on the other end of a telephone, on WhatsApp call, is entirely different. You don't develop the eye contact, you are unable to physically examine, especially for breast cancer patients. I just wanted to know, Dr. Zulkarnain, your experience, that what did you notice? Did you see the same difference?
It's always different, like when you are physically examining the patient, you find out and you pick up and it is always helpful to examine the patient and record them in your recording and then make a plan for their treatment. Yes.
Asad, we can't hear Zulkarnain at all. Can you just ask him to repeat his answer, please?
Okay, yeah, he's coming to the mic.
Yes, I totally agree with Dr. Asad about this, that in physical clinics, you get a lot of information when you are fully examining the patient as compared to the teleclinics. In the teleclinics, you are just relying about what the patient says, and you just on the history make a decision and then plan the patient for the investigations, for the further investigations. But physical clinics definitely are more reliable, and you're physically examining the patients. This is definitely a limitation of teleclinics, that you are not examining the patients. Definitely, I agree with Dr.
Thank you very much. Next, we have a question online, and I would direct that question to Dr. Amna Khan to kindly answer. The question states that during these times, breast cancer patients have been delayed for the treatment. How much delay is acceptable for breast cancer patients?
That's a very valid question, considering that we had suspended our clinical services at the hospital, at least for some time initially, when the initial shock of this pandemic had hit us. So there are two subsets of patients. I think there are patients who were scheduled for upfront surgery, and then there were patients who were coming back after neoadjuvant chemotherapy. So for our upfront patients, we revisited the decisions that had been made in MDT, and we tried our utmost that all of our hormone receptor positive patients could be diverted to medical oncology and be started on hormonal treatment in this interim period, where at least while we were getting to terms with restarting our surgical services, and for that duration, at least, they were on hormonal treatment and not without any kind of treatment while they were waiting for their surgery to happen. So that is what we did with our hormone receptor patients, and these were the majority of patients who were waiting for surgery up front. In terms of our triple negative patients, We try to accommodate them on our lists as soon as possible. And if there were some patients where we thought that they were borderline cases for neoadjuvant chemotherapy, we did ask our medical oncology colleagues to start chemo in some of them after placing marking clips, because our chemo bay had not been put on hold and the chemotherapy services were continuing even during these times when the OR was not operational. So that is how we took care of our pre-op patients. Upfront patients. In terms of patients who were coming back to us after completing chemotherapy, we again put the hormone receptor positive patients on hormonal treatment in collaboration with our medical oncology colleagues and gave priority to our triple negative patients in terms of surgery. Again, the HER2 enriched population that was on anti-HER2 treatment also continued on the anti-HER2 treatment because we felt that it was okay for them to continue on that treatment and they would be able to wait for their surgical intervention without having clinical upstaging in the interim period while we were waiting for the surgical services to continue. So we haven't really seen any patients who had progressed from local disease to systemic disease in this era. There may have been a few transgressions from the optimum times when these patients had been taken to the OR, but I think considering the pandemic and considering that most of these patients are doing well now, I think we managed pretty okay.
That's great, thank you. We don't have any more online questions, but are there any final comments or remarks from any of the participating speakers?
If I could share Amina's experience, because we had difficulties when we had to do sentinel node mapping. The reason being that once you declared a patient COVID negative, and we would recommend that they stay quarantined at home before they would come in for surgery, and then calling them a day before the surgery, which is our routine for mapping, that posed a lot of difficulties because you were potentially then exposing them to another opportunity of contacting. So, you know, we had to then map them on the same day as the day of surgery, and that also took a lot of time. What did you do, Amina? Did you resort to doing them, mapping them a day before or on the same day?
So initially, when we resumed our surgery services and we're doing most of our cases as day cases, we only injected the first case on list the day prior to the surgery, because it would just, you know, we thought it would just not be possible for us to inject them in the morning, then give them the adequate time for waiting and then take them to the OR. So what we did was that the first case on list would be injected the day prior and the rest of the cases would get injected the morning of surgery, which would not give us extra waiting time for the rest of them. So that is what we did. But I completely agree with you. Trying to reduce the number of visits for the patient, be it for sentinel mapping or be it for wire localization, was a big challenge because we were really trying to minimize everything. The other thing that we did also was that we tried to clump together all of these visits, the sentinels pre-op, the wire localizations, and even the anesthesia preoperative assessments were done together when the patients were coming in for these particular tests and pre-op preparations. So that is how we tried to get through with this special challenge.
It's pretty much the same that we face because our ID, you know, control would not allow us, you know, to expose the patient, and especially your anesthesia was also concerned about it. So we're still, and that's what's causing the delay. But luckily, you know, we none of our patients had to go beyond, as we said, the group B, not beyond 12 weeks, within 12 weeks of the diagnosis or after completing the neoadjuvant chemotherapy, we were able to accommodate them within about 6 to 8 weeks time or earlier if possible.
Thank you very much. It has been a very useful session and we must conclude now as the time is running out. I'm really grateful to all the participants, especially Professor Shaista from Karachi and Dr. Zulkarnain and Dr. Amnahan from Shaukat Hanum Hospital. I would like to also thank our organizing committee, especially Anika and Numera, for setting up this webinar and the rest of the webinar that they are arranging. And with this, we would like to conclude the session. Thank you very much.
Thank you.